I am very happy to be here today with you all. My name is Mélody Tondeur. My pronouns are she and her, and I am the manager of metrics at the Canadian Partnership for Women and Children's Health, or CanWaCH for short. I will be moderating this webinar today with the help of my CanWaCH colleague, Ima Enokon. Thank you very much for joining us today from all across Canada, from Nigeria and many other places. We've seen some of you connected from Tanzania, Benin, Burkina Faso, and the UK. So welcome all. Bienvenue tout le monde. I am joining you today from Toronto in Canada, where my home is and where I am grateful to live and work on the traditional lands of many Indigenous peoples, including the Onishoshone, the Wendat, the Anishinaabe, and the Mississaugas of the Credit. Today, we're very happy to be joined by three impressive speakers. We will first be given a quick overview by IDRC on the larger IMCHA project, and then we will be hearing details from the research team at the University of Ibadan on their project addressing perinatal depression among adolescents in Nigeria. Now, about our speakers. The webinar will first, the speakers will be giving their three presentations in a row, and we will be taking some time in the end for a Q&A session. So please feel free to ask your questions at any time during the webinar, and we will address them in the end. The first presentation will be given by Dr. Sana Naffa, who is a senior program specialist at IDRC with the IMCHA initiative. She has more than 20 years of experience in health system strengthening, health research, maternal and children's health monitoring in low and middle income countries. The second presentation will be given by Gureje, who is professor of psychiatry and director of the WHO Collaborating Center for Research in Mental Health, Neurosciences, and Substance Abuse at the Department of Psychiatry at the University of Ibadan. A former president of the Association of Psychiatrists in Nigeria and of the African Association of Psychiatrists and Allied Profession, he has served the World Psychiatric Association as well as the WHO in several capacities. And the third presentation, last but not least, will be given by Dr. Bibilola Oladegi, who is senior lecturer at the College of Medicine at the University of Ibadan. She's a consultant psychiatrist to the University College Hospital in Ibadan and currently heads the department. She has trained hundreds of frontline health care providers to identify and provide evidence-based care for common mental disorders. And now, without further ado, I would like to pass on the mic to Sana, who will introduce us to the IMCHA initiative.
Thank you so much, our colleagues at Canadian Partnership for Women and Children Health. And it's my pleasure to have you all today in this interesting webinar. The perinatal depression in adolescents in Nigeria is one of the 28 research projects in the IMCHA initiatives. IMCHA is the Innovating for Maternal and Child Health in Africa. It's an implementation research project, and the innovation started in 2014 and will end in July 2021. It's a partnership jointly funded by International Development Research Center, the Canadian Institute of Health Research, and the Global Affairs Canada. Next slide, please. The purpose of the Innovating for Maternal and Child Health in Africa initiative is to improve maternal, newborn, and child health outcomes in Africa by strengthening the health systems using primary health care as an entry point. The specific objectives is to address the critical gaps, critical knowledge gaps, and increase awareness among policy decision makers about affordable, feasible, and scalable primary healthcare interventions. and to build the capacity of individual and institutions for gender-sensitive health system and solution-oriented research, as well to enhance the uptake of relevant and timely research that informs policy and practice. As well, it's to strengthen the collaboration between the Canadian and African researchers working in partnership with African decision makers to implement and scale up high quality and effective interventions to improve maternal and child health in Africa. Next slide, please. The initiative started in 2014 and it will end in July 2021. The total budget amount is 36 million, and it included 28 research grants, 19 are original, and 9 were synergy grants. And the research teams are composed of a principal investigator of an African university or research institute or NGO in Africa, and a co-principal investigator affiliated with a Canadian research institute, and a co-PI in a decision-making position, generally at the local, regional, or national government in the country. In addition, 2 grants were awarded to 2 health policy and research organizations in West and East Africa. These health policy research organizations are tasked with knowledge translation and raising the profile of the research in order to facilitate the adoption of the results and scale it up at national and regional level. The West Africa Health Policy Research Organization was the West Africa Health Organization in Burkina Faso, and in the East, it was a consortium of 3 institutions: the African Population and Health Research Center in Kenya, and the East Central and Southern African Health Community in Tanzania, and the Partners in Population and Development in Uganda. 11 countries were involved. The countries are Burkina Faso, Ethiopia, Kenya, Malawi, Mali, Mozambique, Nigeria, Senegal, South Sudan, Tanzania, and Uganda. Please, the second slide. This map shows the distribution of the grants. As you see, 19 original grants and 9 synergy grants, and 2 health policy and research organization, one in West Africa and the other is a consortium in East Africa. And it's important that the role of the health policy and research organization, that they provide an essential knowledge brokering function and directly link the implementation research team to the national and regional outcomes in sub-Saharan Africa. The second slide, please. The 28 research grants were focusing on a number of thematic areas. These were on facility-based high-impact interventions, or community-based interventions, or policy-enabling environment interventions, and human resources for health interventions. And the synergy grants focused on adolescents' health, reproductive health, family planning, with a strong agenda on gender transformative approaches. Now, although the research project focus on one thematic area, but they addressed other themes as well. For example, a facility-based quality improvement research project in Tanzania, beside their work on quality improvement in the facility level, they scaled up the quality improvement process into the community level and as well at the district decision-making level in their district level, making the best use of the decentralized systems in the country. Another example in Nigeria is the home visits community-based educational research project that managed to influence the policy level and managed to institutionalize the home visit program at the district level and as well at the state level in Nigeria. Another family planning program in health facilities recruited and empowered the community health workers to use technology in data collection and health education to increase access to family planning, especially for adolescents and vulnerable groups. We have many good examples. We will keep this maybe to the discussion area and we can move to our colleagues in Nigeria. Thank you.
Thank you very much, Sana, for the presentation. And all participants, we've shared in the chat box some links for you to refer to. And now I will pass the mic over to you, Oye.
Thank you very much, Mélody, for the introduction. And thanks to CanWaCH and the IDRC for organizing this webinar. We greatly appreciate really the opportunity to share some aspects of the work that we have been doing on women mental health, specifically maternal mental health, over quite a few years now, funded mainly by institutions in Canada, as you can see on the slide. It is in the context of this range of activities that we have come to see the importance of adolescent perinatal depression, especially to recognize this area of health as one that requires much more focus and attention. Next slide, please. So today, my colleague and I will be going through a number of areas relating to adolescent maternal issues. We'll be talking about adolescent pregnancy, as highlighting the scale of it globally and especially in low and middle income countries. We will talk about perinatal depression among adolescents, its occurrence and its impact. And specifically, we want to highlight the differences between adolescents and adults who suffer from this condition. And in doing so, to draw attention to what might be a big gap in terms of the health system response to this problem among adolescents. And then finally, my colleague will then describe what we are doing to try and address this gap in the project responding to the challenge of adolescent perinatal depression that we are conducting in Ibadan. Next slide, please. So pregnancy among adolescents is actually quite a global issue. The WHO estimates that 11% of all births are to girls who are between the ages of 15 and 19 years. And the World Bank estimates that on average, 44 births per 1,000 adolescents occur across the world, with a range from 1 to 201 across countries. And indeed, those high rates happen to occur in low and middle income countries. And in fact, the highest rates occur in sub-Saharan African countries. For example, in Nigeria, about 30% of all women will have had a birth before the age of 18. And in this country, that's Nigeria, the birth rate is about 109 per 1,000 adolescents. So it's quite a big issue, both globally, but more specifically in low and middle income countries. Next slide, please. Perinatal depression, which is a non-psychotic episode of depression that often begins during a pregnancy and extends into the postnatal period, is actually quite a common problem among adolescents. If self-report is used, you might get rates ranging between 8% and 47%. That is when they themselves provide the response to questionnaires. But when clinicians administer the assessment and make the diagnosis, between 16% and 26% of all pregnant adolescents will have perinatal depression during this perinatal period. So it's quite a common experience among adolescents. And it comes with a range of consequences, which will be shown on the next slide. Next slide, please. So come on, no, not before that, please. So some of the consequences include preterm birth and low birth weight, their babies, increased risk of further unplanned pregnancy. That is when an adolescent get pregnant and then have developed with depression, then there is a higher risk that they might have another pregnancy which might be unplanned. And they tend to have poor parenting skills manifested by use of aggressive parenting behavior in bringing up their children. And this problem is often also commonly associated with growth and developmental disease. Quite a number of reports have described stunting and growth delay among infants born to adolescents who suffer from perinatal depression. And some of these problems often translate to higher levels of psychopathology in their children when they grow up. Next slide. So we conducted a randomized controlled trial in the southwestern part of Nigeria, as shown on that map, in which we selected women from a broad range of clinics, both urban and rural. And we wanted to address two main questions in this particular presentation that I'm making today, which is how different are adolescents and adults with perinatal depression in regards to the impact of the condition. That is, the perinatal depression is common across different age groups, but adolescents quite different in terms of the impact and consequences of this condition on them. And then in terms of treatment, what is the difference in outcome between them? Do they respond the same way? Are there differences in the way they respond to commonly established effective treatment, especially those that have been shown to work in adults? Next slide. So that study, it's called Expanding Care for Perinatal Women with Depression, Exponate. We actually compared two forms of intervention. One that was sort of low-grade psychological intervention, which we call low intensity, and one that was much more intense in terms of the number of times or the number of therapy sessions that the women had to were given in order to treat their perinatal depression. And these women were entered into the trial usually in their second or third trimester, and they were followed up until 6 months postnatal. So we wanted to see what differences there were between adolescents and adults in terms of this treatment modality or these treatment forms that we instituted in this setting. Next slide. The population that we screened over 9,000 women, of which just over 8% were adolescents. and out of the 9,000, more than 727, or about 727 had moderate to severe depression, and about 19% of these were adolescents. So that provided us with this opportunity to compare adolescents with adults, both in terms of the impact of the condition and also in terms of the outcome of the treatment. Next slide. So what we found, this is just summary of quite a few things that we found. Well, the one is to confirm what's been reported in some other settings, which is that perinatal depression is much higher among adolescents compared to adults. In fact, in our own setting, almost 3 times higher than in adults. There was a range of problems for adolescents compared with adults in pregnancy, in terms of attitude, in terms of acceptance, but in terms of compliance with treatment, we found that they were less likely to comply with treatment. That is, they were more likely to miss quite a number of the therapy sessions that we instituted to treat the condition. They were more likely to have low birth weight infants and smaller gestational age at delivery, and also to have undernourished infants at 6 months postnatal. Even though they responded to the treatment in terms of their depression, in terms of remission of their depression, but we found that they continued to have persisting parenting skill deficits at 6 months postnatal compared with adults. That is, even though the treatment seemed to address their symptoms, it didn't actually do all that was required to make them become good mothers. Next slide, please. So it will appear that what works for adults with perinatal depression may not be adequate for adolescents. There's no deficit that we have seen. They're probably indicative of the fact that the health system has not really come to grapple with the special needs of these mothers. So we think that there is a need for the health system to design and to become more responsive to their peculiar needs in order to respond to some of the things that they have that adults may not necessarily have, like this persistent parenting skill deficit. Next slide. We looked in the literature and to see whether in fact people have addressed this problem. Globally, we found that in fact there was very little attention to treatment targeting adolescents with perinatal depression specifically. Very few studies have been conducted, and many of those studies were really very small samples, not usually strong randomized controlled trials. And certainly no such study have been conducted in any of the low and income countries that we have examined in the literature. So there's really quite a big gap there in terms of addressing the issues that adolescent mothers might have. Next slide, please. So that gap is what we think needs to be filled. And in order to fill that gap, there are quite a number of things that we think will be required. One is that the intervention package that will be designed for adolescents needs to be age appropriate, which goes without saying, not just because of the peculiarities of pregnancy, but also peculiarities of adolescence at a biological milestone in life. Also, the intervention needs to take into account the peculiar gender issues around that age group. And we think any kind of intervention that will be designed in that way should have a strong focus on psychological approach. This is because, of course, many women are quite reluctant to take medication during pregnancy, and in fact, clinicians are also quite reluctant to prescribe medication. And in fact, we have quite mixed evidence about the risk of antidepressants. So there's a need to try and avoid that route in terms of addressing perinatal depression in adolescents. Any such intervention also must address the peculiar problem of parenting skills that I've highlighted before. Some of those deficits do translate to problems in the infants and also in the children as they grow up. And we think that this kind of intervention needs to be delivered where adolescents actually go to receive care. Even though we know that there is some difficulty in getting adolescents to come for treatment, especially when it's targeting mental health issues specifically. But we do know that there's a high rate of uptake of antenatal care. In our country, for example, more than 90% of adolescents will actually take antenatal care, take up antenatal care routinely. So it will be a good thing to try and integrate this kind of intervention for depression within the perinatal care that adolescents will take up anyway. And any kind of intervention that is designed in that way will need to be put through rigorous trial to show that not only it works, but also that it is likely to be scalable, that it can be scaled up into routine care. Next slide. It is this gap that we have set out to fill by designing this study responding to the challenge of adolescent perinatal depression, which my colleague will be describing how this was designed and how we are rolling this out to adolescents and the experience that we have gained so far. Thank you very much.
I would like to just join my voice with that of the other panelists to appreciate the CanWaCH for having us this afternoon present some of the work that we've been doing with adolescents in Nigeria. Next slide, please. The responding to the challenge of adolescent perinatal depression, or the RAPID for short, is one of the synergy projects mentioned earlier by Sana in her introduction to the IMCHA project. It is a hybrid effectiveness implementation cluster randomized control trial, and the purpose of the RAPID study is to explore how the effectiveness and the utility, as mentioned by the earlier presenter, that whatever is designed, the package needs to be scalable. So it is to look at how effective that specially designed intervention package that we had for adolescents would be in trial. Next slide, please. So the RAPID project was conducted in 28 selected primary healthcare centers, like the ones pictured here. The picture above just shows the entrance to one of the primary care centers. And the one below is the waiting area where the mothers gather for health talks before the clinic starts. And this is where from here is where they're now distributed to various rooms to see the providers. So these primary healthcare centers were randomized into two groups. One arm is the intervention arm, where our designed intervention package is being implemented. I'll describe that a little bit more in a later slide. And in the other arm, the other 14 clinics is where the adolescents adolescents in those clinics basically receive usual care. So for the project, every adolescent that is presenting in pregnancy to these clinics to register are screened with the Edinburgh Postnatal Depression Scale. Everyone, that is mothers that are below 20 and score above 12 on the EPDS screen, they're the ones that are enrolled into the study. Next slide, please. So to In those clinics, over the time of the project, we screened a total of 1,237 women that were aged below 20 years. And out of these, 223 of them, which is about 18%, just like what we found in the earlier study that we conducted, had perinatal depression. And preliminary exploration of that data is pointing to certain things. And one of it is that the younger adolescents are more likely to have depression. And we can see that the rate of depression in the younger one, aged between 14 and 17 years, is 27.9%, compared to about 16.4% in those who are above 18 and above. And another thing that we noticed about the adolescents that had perinatal depression is that they were less likely to be living with a partner. And they were also from poorer socioeconomic backgrounds. And this was indicated by the fact that they had higher rates of food insecurity. That in this program, we defined as having to go to bed hungry in the last week for at least one day because there was no food to eat. So there were higher rates of those adolescents in the group with perinatal depression compared to the group that did not have perinatal depression. Next slide, please. Before I go on to describe our interventions, I would like to give us more of a background of what informed the design of the interventions that we used. So as part of the formative process for the project, we carried out this qualitative study. And what we did in these focus group discussions, we had 6 of them, was to interact with purposely selected adolescent mothers. These women were, as of the time when we had the earlier randomized control trial, they were adolescents that were part of that trial. So we purposely selected them to reflect various groups in terms of how well they participated in the interventions for depression in that earlier trial. I wanted to explore what factors made those that attended well their intervention sessions, what made them attend, and the others that were not attending, why did they not attend the session? So we had these purposely selected adolescent mothers, and we also had 3 groups. There were 3 groups of the mothers, and then 3 groups of primary healthcare providers, who were the usual frontline providers that provide care for these adolescents in the clinic. Next slide, please. So for those who attended the service, some of the things that they said that made them attend the service was the perceived benefits that they were receiving from the care. And one of them said, I was in a very bad state when I went to the clinic. I thought my life was over. However, the more I visited the clinic and talked to the matron, the better I felt. And those that also felt that the provider that was seeing them was supportive were also more likely to attend their sessions. Next slide, please. The barriers that we found to service use were related to 2 things. One is the negative stereotypes by the providers. So the providers expressed opinions such as the fact that these girls are rude, they're typically difficult to attend to, and some of the providers had a negative attitude towards them, kind of like punishing them for getting pregnant, which is kind of in keeping with the cultural negative view of adolescents who are not married and then they get pregnant. Next slide, please. And the adolescents also, sorry, please, can you go back? The adolescents also felt stigmatized by the providers. And this is exemplified by this quote by one of them. She said, I had a bad experience one day with a nurse. She was the one that checks everyone to see if the babies are breathing. She was always rude to young people. She told me that I got pregnant when my mates were in school. I felt very worthless. I answered back and told her she was a bad person. I refused to let her attend to me after that day. So we can see that the adolescents felt quite stigmatized. Can we go to the next slide, please? In addition to not being welcome in the clinic, these adolescents also had a lot of difficulty with their families because of this unwanted and unplanned pregnancy. So a lot of them were rejected, were not supported by their families. And not just that, so many of them were also rejected by the father of their child. Next slide, please. So putting all this together, we knew that designing intervention for adolescent perinatal depression had to include elements of self-care. It had to provide support for their parenting skills. And we also realized that if the adolescents are going to take up service, the providers also would need a change in their attitude towards these adolescents. So whatever intervention had to address these two areas. Next slide, please. So for the training of the healthcare providers, we adopted a similar pattern that we have had and we have found to be effective in our earlier interactions with the healthcare providers. So the sessions, we had them come in for 3 days, because they've already had earlier training. Some of them had earlier trainings on intervention for depression, but this was to now focus their training on taking care of these adolescent mothers. So similar to other trainings, we had teaching sessions where we provided and taught them on various topics, and then they broke out into groups. And we also incorporated role plays. And for role plays, the providers are in groups of 3 or 4, and each one of them takes turn to practice the interventions that they've been taught in role play, while one of the other providers acts as an adolescent woman presenting to the clinic, and then the third acts as an observer to kind of document what they did well, the areas that the provider did not touch. So the training was in that similar pattern to what we've always done. Next slide, please. So to just speak a little bit about the content of the training, we started by giving them feedback of from the focus group discussions, what the adolescent felt about them, and also some of the things that they also said about the adolescent. And we spoke about, because one of the things that came out was that they felt these adolescent girls were very rude. We spoke to it that it might actually be adolescent, some of the things that they counted as rude might actually be normal adolescent behavior. So we made them understand that, and also emphasize the social implications and complications of adolescent pregnancy. And we spoke about depression and how to counter it. Next slide, please. Okay, so our interventions, as mentioned earlier, we had interventions for depression and also some focus on parenting skills. Next slide, please. So there were 6 sessions that the adolescents were expected to have prenatally, and these 6 sessions were structured. The providers knew they had charts that helped them to know what they had to do with each session. And the first session basically is to introduce them and the adolescents, and then to let the adolescent know what they'll be speaking about. And this manual was we developed a manual that was well illustrated, and we also had patient information booklets that also had a lot of illustrations. Next slide, please. Just to show some of the content of the manual and the patient information booklet. So this pictures just shows, introduces the adolescent and the providers with a way of letting the adolescent understand the symptoms of depression and some of the things that they needed to do to help them to get over it. Activity scheduling, that is the importance of scheduling a pleasant activity every day in helping the adolescent to recover from depression. Next slide. And problem-solving treatment was a key component, and this just illustrates the various steps of problem solving, both to help the adolescents address their current problems and also to teach them problem-solving skills that they could apply into their lives in future. The next slide, please. As we mentioned, that our intervention had to be strong on parenting skills, because in the last program, we discovered that even though these adolescents did well in terms of recovery from depression, their parenting skills were still poor. So with each session, the providers had to take the adolescents through various aspects of the parenting skills, which we divided into 4 aspects. One was taking care of themselves. Second was how they needed to prepare for the baby, the different signs of pregnancy. labor and delivery, the items they needed to get, and then to also educate the adolescents about how to care for their newborn and infant development, and also to let them know how to respond to their babies. Next slide, please. I would like to emphasize on this. One of the things that we discovered in our interaction with the adolescents, that even though a lot of them had problems with their social support because they were pregnant, some of them felt that in the course of getting pregnant, that they had like an older woman that they could relate with, who was sometimes more helpful to them even than their family members. So as to support parenting skills, we had each adolescent identify an older woman who was supposed to be an experienced mother. For the purpose of this project, we call these ones neighborhood mothers. And we were not really strict about who the adolescent could pick, but the person had to be somebody that the adolescent could relate to, somebody that the adolescent felt they could trust and was easily accessible to them, could provide support for them in caring for their babies. And this woman had to live within walking distance. What we found from my experience on the program is that some of them actually chose their mothers because they felt their mothers were supportive enough, but others chose neighbors, some others chose some aunts or cousins. Were really not specific about who they chose, but this woman had to just be somebody that they could relate to and they knew can be there to support them. So this woman had to accompany the adolescent to the clinic on one or two occasions to be trained by the provider so that they can fit into this role. And the role that they were expected to fit into was to visit the adolescents as often as possible following childbirth and to support the adolescent in caring for herself and her infant. Next slide, please. So in wrapping up, I just want to just mention this case. This was one of the story of one of the adolescents on the program. She's an 18-year-old girl who was raised by her grandma because both parents are separated from when she was a child. And after high school, she was sent to learn sewing so that she can become a tailor. And in the course of that, she got pregnant. And the father of the child is a 23-year-old man who was already married and had 2 children, so he didn't want anything to do with her. And because she was pregnant, the grandmother didn't want anything to do with having to take care of another baby in addition to her. So she became quite hostile and literally told her to leave. But she reached out to her parents. None of them was willing to accept her. Please go on. Next slide. And in the course of this, one of the neighbors told her to register at a nearby primary health care center. And that center happened to be one of the places where this project was ongoing. Her EPDF score when she was screened at the center was 17. And at that time, she had suicidal ideas. She was fed up of life. The primary care provider that she met worked with her. And in the course of working with her, using the interventions that they were taught, was able to help her resolve the differences she had with her grandmother, also negotiate with the man to get her child support after she delivered. And meanwhile, they were able to support her and give her a part-time job in the clinic so that she could support herself. And after subsequently continued with her training, and after she was delivered of her baby, she went back to the training to complete her training. And the primary healthcare provider also helped her in getting the equipment that she needed to set up on her own. Next slide, please. So this case highlights the changes in attitude of the primary care providers and the clinic environment, that it is now more welcoming, and the providers are actually reaching beyond themselves to help these adolescent mothers. Well, we keep our fingers crossed and hope that the evidence that we're going to get from our data will support the effectiveness of these interventions. We can learn more about our study from the publications from the study, the protocol, and then the formative study that I spoke about earlier. Last slide, please. I would like to appreciate our funders for their support in all through the time that this project is running, and even up till now, which is what has led up to this presentation. Thank you so much for listening.
Thank you very much to our three speakers for your presentation. So we now have a few questions that we've received and one comment. So I would like to welcome the three panelists here with us to answer to those questions. So the first question that we got, so the participant mentioned that poor parenting skills have been observed among youth with unplanned pregnancy who are not depressed. The parenting problem may therefore extend beyond adolescence and depression. As Professor Gureje mentioned, the youthful phase of life may be a major factor. Now the question is, are there any parenting packages for adolescents and youth which we can implement among young mothers, whether they are depressed or not?
So Mélody, could you repeat that, the last part of that question?
Yes, absolutely. And I apologize, I think my connection went unstable. So the question is, are there any parenting packages for adolescents and youth which we can implement among young mothers, whether they're depressed or not?
Right, yes, of course, there are. The WHO had they've done quite some work on parenting skills, and there are publications and packages that the WHO has developed, and I think some of those can be accessed online, free, that will address that question, not specifically for adolescents with perinatal depression, but in general, in terms of improving parenting skills, and also not necessarily just among adolescents, but it can be applied across a broad range of age groups. Yes, there are packages developed by them, and I'm not sure really whether, in fact, one might also be able to get packages developed by UNESCO and some other groups like that.
Thank you. Now the next question is for you, Bibi. From your experience with these adolescents, what are those factors that commonly predispose them getting pregnant?
Okay. Several factors predispose them to getting pregnant. Like in our setting, poverty is a major one, because a lot of these adolescents are from very poor background. So poverty has been linked to increased rates of pregnancy in adolescents. Other issues that related to that, they're not being in school is also a key factor, because also likely related to the poverty in these adolescents.
Yes, in some countries, education up till the age of 16 is mandatory, is compulsory, but that's not the case in Nigeria. The education in primary care is what is mandatory here, which is up to the age of maybe 11 or 12 or something like that, which means a lot of adolescents are not in school. And as my colleague has mentioned, of course, that's a big risk factor for getting pregnant, and especially when they then get engaged in all sort of trading activities and child labor and all of it, which may be related to that overarching issue of poverty. Yes.
Thank you. Now we have another question from a participant. Will it not be wise to also focus efforts on holistic reproductive healthcare services?
Well, to speak to that, I think one of the things that we're doing, since we're working with the primary healthcare providers who are the forefront of taking care of everybody that registers for antenatal care, so improving their skills, improving their attitude also would help them in taking care of every other patient, whether they are depressed or not. So our intervention is not just going to help them in caring for adolescents, even though it's really focused on those with perinatal depression, but it's also useful for general reproductive healthcare services. And part of the things, even though I didn't mention it, part of the things that we also emphasize during our training for their parenting skills training is for them to also talk to these adolescents about family planning so that, you know, they don't keep coming back. Like some of the adolescents that we invited for the preliminary study, the formative, the focus group discussions, they were pregnant adolescents about 2-3 years before when we had the first clinical trial. Some of them came in with another baby. So within that time, some of them had had 2 babies within the space of, you know, like 3 years. So part of what we also encourage the primary care providers to talk about is family planning so that these adolescents don't keep getting pregnant and, you know, continue with this cycle of poverty.
Thank you. And now this is the last question that we'll be able to address today. Any idea on the rate of family planning uptake postnatal for these adolescents? Healthcare workers providing family planning services in Nigeria have been known to discourage adolescents and single ladies from uptake.
That's very true. And that is one of the things that we try to address in training these healthcare providers so that they know that if we don't take care of this, these adolescents will continue coming back. And I think that was kind of exemplified by the case that I spoke about, helping the adolescents to kind of get a livelihood so that, you know, they can take care of themselves is also something that is key in preventing them from getting pregnant. In terms of the uptake of family planning, we don't know that yet because the data is yet to be fully analyzed. So it might be some of the things I'll be able to speak to after the study is completed.
Thank you, Bibi. And maybe one last one here that we can fit in our timing is Dr. Gureje. Mental health is still perceived as a taboo discussion in Nigeria. We're hearing from the participant who is asking the question. How can we embed mental health care services in healthcare centers, especially in rural areas?
Yes, yeah, so we have quite a few hurdles, and one is at policy level, but one is the issue about stigma and the attitude of the providers even to talk about mental health service and providing same. But as we have shown, these providers are actually quite trainable. They can be trained to change their attitude, and they can be trained to acquire the skill necessary to for delivering basic care for most common mental health conditions, not just depression, but some other conditions that we have also dealt with. But in order for all of this to happen, there need to be a higher level of policy attention to integration of mental health into primary care, so that not only will that allow or encourage in-service training for the providers to be trained in the identification and treatment of mental health conditions, but it also incentivizes them to attend to mental health conditions in various ways, not necessarily through just monetary incentive, but also through proper record keeping. If providers know that whatever service they render will be documented, just as they document for hypertension and diabetes, then they will be more likely to be willing to address mental health issues. So there's a whole range of things that need to be done in order for integration to happen, not just in rural areas, but even in urban areas as well. Because in any case, the number of specialists in many of the countries that we're talking about is really very, very, very low, irrespective of the fact that many of them will be in those urban areas.
Thank you very much to you all. So now I would love to pass the microphone to Sana for a wrap-up before I close this webinar. Over to you, Sana.
Yeah, thank you, Mélody. And I want to thank our outstanding speakers, Dr. Oyi and Dr. Lola, and the research teams at the University of Ibadan and McGill University and the Oyo State Primary Healthcare Board members for all their good work in Nigeria. And this gives us like a taste of the importance of investing in primary healthcare. It was really very interesting to hear this story, and there are other many stories within IMCHA that highlight the importance of investing in primary healthcare to reach all the hard-to-reach groups and to achieve health equity for all, and at the same time to decrease the burden on hospitals, which are already overwhelmed, especially now with the COVID-19. So I really appreciate this work and all the work that is done by the IMCHA 28 research projects. And I encourage you to visit our website at IDRC and to follow up on the Innovating for Maternal and Child Health initiative in these countries. Thank you so much for CanWaCH, and it is really interesting webinar.
Thank you to our wonderful speakers. Thank you for sharing your important work. And thank you to all the participants and for your question and your engagement. And my colleague shared her contact information in case you want to send us more questions or comments. And you will all be receiving a copy of the webinar recording with all the supporting material we shared with you today. So thank you all, and we wish you to have a good rest of your day.